The top 5 chest seal mistakes that kill. Sucking chest wound. Shh. Those 3 words hit harder than February sleet. You see the red froth. You hear that wet click every time the casualty breathes, and every instinct screams, cover it. So you shred the wrapper, slap on the sticker, and boom, hero moment for 3 seconds. Then their breathing gets faster, lips go dusky, and the pulse disappears. You just made one of the top 5 mistakes that can turn a fixable injury into a fatal one. Stick around. In the next few minutes, you'll learn the critical errors that kill and how never to make them. Mistake number 1, the slap and pray. This is the number 1 killer. Premature placement. It's not about the brand or the shaky hand. It's about putting the seal on before doing one ridiculously simple thing. Under stress, we want to stop the leak now, but the rib cage is a mess of blood, sweat, grit, tears, mud. Sticking a seal on that slip and slide leaves micro gaps. Air leaks in, pressure builds, and a tension pneumothorax develops. One study pegged a bad seal as a direct cause of this deadly condition. It's not the product's fault. It's an application error. Think about it this way. You're trying to stick a Band-Aid on a wet windshield. The adhesive might stick for a second, but the moment any force hits it, the patient's breathing, movement, or transport vibrations, those edges start lifting. Each gap becomes a pathway for air to enter the chest cavity. And once that happens, every breath pumps more pressure into spaces where it does not belong. Fellow combat paratrooper medic out of the 82nd Airborne Division once told me, I've seen perfect kits fail because the wipe got skipped. Those 82nd Airborne Division combat medics apply seals while tracers zip past their heads. You got to listen to them. The skin prep isn't optional. It's the difference between success and watching your patient go deteriorate before your eyes. Here's what actually happens when you skip the prep. Body fluids create a barrier between the adhesive and the skin. Blood has proteins that interfere with the bonding. Sweat contains salts and prevent proper adhesion. Dirt and debris, they create physical gaps that air exploits. Even the finest particles become microscopic doorways for pressure equalization. The fix is simple but non-negotiable. Wipe first. Grab gauze or a gloved finger and drag it in a circle, one swipe clockwise, one back. You're not performing surgery here. You are creating a clean surface for the adhesive to grab. The skin goes from slick to tacky in seconds. That tackiness tells you the adhesive will now have something to bond with. Now, and only now, are you ready to apply the seal. Don't overthink this wiping technique. You're not trying to sterilize the area. You're removing the slippery layer that prevents adhesion. A firm, confident wipe removes the surface contamination while the body's natural oils help the adhesive form a proper bond. Some medics carry alcohol wipes for this step, but honestly, any cleaning cloth will do if you apply it with purpose. Mistake number 2, the one and done. You found the hole. You wiped. You sealed. Job done? Not even close. A common error is forgetting to check an exit wound. Bullets rarely stay put, and the human torso isn't a target at the range. It's a 3-dimensional maze of vital organs wrapped in muscle and bone and a lot of blood. If there's an entry, there must be assumed that there's an exit wound until proven otherwise. This is not paranoia, folks. It's physics. Projectiles follow predictable paths through tissue. And what goes in always comes out somewhere. The exit wound is often larger than the entry due to tissue expansion and cavitation. It also frequently hidden in places you don't find with a casual glance. Systematically check the entire torso. Roll the patient. Inspect the back, sides, and under the arms. Don't forget the areas where clothing bunches up or where body armor meets bare skin. Exit wounds love to hide in the shoulder blade where they're obscured by natural body contours. Each hole gets its own seal. This isn't about being thorough for the sake of completeness. It's about understanding that multiple wounds create multiple pathways for pressure problems. You can have the world's most beautiful, perfect seal on the entry wound, but if it's an unsealed exit wound, you've accomplished nothing. Air will find the path of least resistance, and the second hole becomes your new point of failure. Here's a new real-world example. A medic in Afghanistan found an entry wound, center mass, and applied the perfect seal. Patient seemed stable for the first 10 minutes. Then respiratory distress kicked in. Heart rate climbed, and the blood pressure bottomed. The exit wound was tucked under the patient's left armpit, invisible until they rolled him and loaded him onto the stretcher. By then, air had been building up in the chest cavity for nearly 15 minutes. Ignoring a second wound is like plugging one hole in a sinking boat, while the bigger one is just wide open below the waterline. The physics don't care about your good intentions, folks. Secure the scene, put gloves on, strip the torso, check the front to back before you even think about moving on. This systemic approach takes maybe 60 seconds, but those 60 seconds separate the professionals from the newbies. Don't let clothing fool you either. Fabric can mask wounds, especially in areas where it's thick or layered. Cut clothes away if you need to. Modesty takes a back seat to breathing. And remember, some wounds don't look like textbook photos. Exit wounds can be ragged, partially sealed by clothing, or even closed by muscle tension. Trust your systemic approach over your assumptions. Mistake number 3, believing the duck myth tape. Any seal beats no seal. Wrong. And its cousin, duct tape, works just fine. It's just as deadly. A leak, improvised seal can hide the problem until the patient crumps and giving you false confidence while the underlying injury gets worse. In the real world, sweat and blood turn duct tape into useless confetti, leaving a gluey mess that the OR hates. The adhesive on the duct tape is designed for dry surfaces and moderate temperatures. Human skin is very wet, warm, and constantly moving. Add the salt from the sweat and the proteins from the blood, and that reliable duct tape becomes a temporary inconvenience at best. Here's a more dangerous point. Duct tape fails progressively. Unlike a proper chest seal that either works clearly or doesn't, duct tape peels back slowly. It starts in the corners and works inward. Tape. Don't use this kind of tape, folks. Don't use this kind of tape. The patient might seem stable while air slowly leaks in with each breath. By the time the failure becomes more obvious, you've lost precious minutes and the patient is in worse shape than when you started. While some old school advice involving taping plastic on 3 sides, this method is unreliable and often fails in practice. The 3-sided seal was supposed to create a flutter valve effect. You want to know, back in AIT days for me, that's how we were supposed to learn how to do it. A 3-way chest seal, and you leave the low app open to vent or burp it. In reality, the unsealed edge either stays stuck or fails completely, providing no benefit at all. I've seen medics try to use everything from electrical tape to medical tape with plastic wrap. Here's what happens. Electrical tape has aggressive adhesive that can damage the skin during removal, but it lacks the flexibility to move with breathing. Medical tape is gentler, but it wasn't designed for this application. It fails when exposed to bodily fluids. Plastic wrap bunches, wrinkles, and creates air channels no matter how carefully you apply it. Commercial chest seals exist for a reason. They're engineered with medical-grade adhesives that bond to the skin. The backing material is designed to flex with chest movement without losing its seal. Vented models have been tested under conditions you'll never recreate with improvised materials. Stick to the commercial vented chest seals. Physics trumps brand loyalty, but a purpose-built trump device from a hardware store. Stick to a commercial vented chest seal. Physics trumps brand loyalty, but a purpose-built device trumps hardware store solutions every single time. The cost difference between a real chest seal and and improvised is measured in dollars. The performance is measured in life. If you're in a remote area and improvisation is your only option, understand that you're using a temporary measure at best. Get the patient to definitive care as possible and monitor them constantly for signs of deterioration. Don't kid yourself that duct tape and plastic are equivalent, because they're not. But treat proper adhesions as the life or death step that it is. Mistake number 4, forgetting to burp the seal. You've wiped, you've found both wounds, and you've used a chest seal. But what kind? This question matters more than most people realize, because different seal types require different management approaches. Vented seals with one-way valves are forgiving. They hiss extra air out automatically. These devices include a small valve mechanism that allows air to escape from the chest cavity while preventing outside air from entering. They work properly. They're almost foolproof. You apply them and they manage the pressure automatically. Non-vented, though, they require active management. If you use a non-vented or a fully occlusive dressing, you've sealed the wound. That's great. But you haven't stopped the potential air leak from damaging the lung inside. Each breath can pump more air into the chest cavity with no way for it to escape. This builds pressure and gets more dangerous with every single breath. Here's the physiology. When a lung is punctured, air can leak from damaged tissue into the pleural space, the area between the lung and the chest wall. Normally, this space contains a small amount of fluid that helps the lungs move smoothly during breathing. When air accumulates there, it takes up space and prevents the lung from expanding properly. As more air builds up, eventually starts pushing against the heart and major blood vessels, creating a condition called a tension pneumothorax. The fix is to burp the seal. If you see signs of worsening respiratory distress, such as faster breathing, increased anxiety, oxygen levels are dropping, or increased heart rate, you must lift the corner of the seal for a moment to let the trapped air rush out, then reseal it. You'll hear a hissing sound as the pressure equalizes. It means you release the air that was building up where it does not belong. But timing is critical. Burp too early and you're introducing air unnecessarily. Wait too late and you're watching the patient develop a tension pneumothorax in live time. The key is to watch clinical signs of pressure build up, increased difficulty breathing, agitation, confusion, rapid heart rate, or decreasing in blood pressure. Some medics are hesitant to burp the seal because they're worried about breaking the seal or introducing contamination. Yeah, these are valid concerns, but they're outweighed by the risk of a tension pneumothorax. When you burp the seal, just lift one corner, enough to allow the air to escape, but not so much that you compromise the entire seal. Do it quickly and deliberately, then press the corner back down immediately. The burping technique isn't just about lifting a random corner. Feel for the area of the seal where there's less adhesion, usually near an edge where the curve of the ribs, it creates a natural lift. Lift that spot gently until you hear the air escape, then immediately reseal. This process should take about 2 seconds. Failing to manage non-vented seals properly turns your solution into the cause of a tension pneumothorax. You've gone from helping the patient to actively making their condition worse. This is why many protocols now favor vented seals over non-vented ones. They remove the human factor from pressure management. Mistake number 5. The fix it and forget it mindset. The final mistake, assuming, is the job is over once the seal is on. The mentality is understandable. You've identified a problem, you've taken decisive action, applied a solution. Your brain wants to check that box and move on to other priorities. But a chest seal doesn't fix the underlying injury. It buys time. and that time is only valuable if you use it wisely. You must constantly reassess. This isn't casual observation, it's systemic monitoring of specific indicators that tell you whether your intervention is working or failing. Watch the chest rise and fall. Normal breathing has a regular rhythm and relatively equal expansion on the left and right. If you notice that one side is moving less than the other, or the patient is using accessory muscles in their neck and shoulders to breathe, these are signs that something is going south. The chest wall should move smoothly and symmetrically. Any deviation from this pattern suggests your chest seal might not be working, or that the pressure is building up inside the pleural cavity. Monitor the respiratory rate and quality. Healthy adults breathe 12 and 20 breaths per minute. Injured patients will breathe faster. But if that rate keeps speeding up, over 30 breaths per minute, you know that they're in respiratory distress. More important is the quality of breath. Are they having a hard time getting air in? Are they making noise when they breathe? Are they unable to speak in full sentences? Track their heart rate and mental status. Is their heart rate climbing? Are they becoming more anxious or confused? The heart compensates for breathing problems by beating faster, trying to get more oxygen to the cells. A climbing heart rate often precedes other vital sign changes. Mental status, confusion, agitation, anxiety. That tells us that the brain is not getting enough oxygen. Watch for the late signs of imminent danger. A deviated trachea starts to shift away from the injured side, or the neck veins become bulged and distended. These are signs of a severe pneumothorax. These findings indicate pressure inside the pleural cavity has become so high that it's pushing against the heart and the major blood vessels, preventing them from functioning. At this point, the patient is just minutes away from cardiovascular collapse. Your most important assessment is your reassessment. The initial evaluation tells you what's wrong now. The reassessment tells you if your treatment plan is working or different interventions need to happen. Monitor vitals every few minutes, not every couple hours. If you notice deterioration, maybe you need to burp the seal. Or if you have the training, decompressed with a chest needle or surgical procedure, like a chest tube. But we're not doing that in this video. These are advanced interventions that require proper training. For most first responders, the key is to recognizing when your initial treatment isn't sufficient and getting the patient to someone with more advanced capabilities. Check breathing and rate every 2 to 3 minutes. Look at the skin color. Are they getting pale or blue? Can they still talk? Or are they speaking in short phases between breaths? Watch the level of consciousness. Are they alert? Or are they anxious or confused or obtunded? The seal is just one. Constant vigilance is what keeps the patient alive. This isn't about being paranoid or obsessive. It's about understanding that chest injuries are dynamic. They can improve with proper treatment, but they can also deteriorate rapidly if complications develop. Your job isn't finished when you apply the seal. It's finished when you hand that patient off to someone like me. Gear helps. Training is better. But tiny details decide who walks away. These are 5 mistakes. The slap and spray, the one and done, the duct tape myth, forgetting to burp, the fix it and forget it mindset, all are preventable. Next time you crack that, open that chest seal, remember the fundamentals. Swipe from front to back, use the right gear, and reassess constantly. The hold doesn't finish the job. Preventable pressure wave does. So we discovered our chest injury right here. Oh, look, got a chest injury here. We're going to put a chest seal on. Wipe this bad boy down. A little bloody. Nice and dry. It's going to be okay. Yeah. Make sure it's sealed around. Make sure it's sealed around. All right, let's reassess you. Check your blood pressure. Come back to you. We're going to have to triage somebody here in a minute. Oh, no. I can't breathe. I can't breathe. I can't breathe. Okay, I'm going to help you out here. I want to burp this seal, okay? Yeah, let's just do it from here. There you go. How's that? You just bought yourself a chest tube, buddy. It's okay. It's okay. Thank you. Thank you. Here's something to help you relax. All right. We'll come back in a few minutes.
A few moments later.
Okay, let's see here. If I looked for an exit wound, we got that closed off. Got this chest seal. We're gonna get you out of here, okay? Okay. Okay. Thank you. Thank you so much. Thank you. Don't lose your dentures, good buddy. Okay, I won't. Thank you. Thank you for saving me so much, Suburban Prepper. You're welcome. Thank you so much. This is survival. This is resilience. This is Suburban Prepper.